Okay, thank you. And June, thank you for the opportunity to speak to you guys. So I am basically just finishing up my training, and we'll be doing a research year next year with Dr. Viravago, as June said, and then transitioning to do a complex spine fellowship, and that will also be an instructorship as well. Because of my interest in neurosurgical oncology, and more specifically, I'm interested in spinal oncology, and so having and I'll talk about this a little bit later, having that complex spine skill set will be helpful going forward. So basically, I want to make this as interactive as possible. I know this is kind of a shadowing experience for you guys. And so, and I'd like this to be as informal as possible. So if you guys have questions along the way, please do stop me. So I'm going to talk about basically the neurosurgical oncology fellowship experience in a very general way. And I'm going to talk about this in the context of the year I spent at Yale, because this year I'm doing neurosurgical oncology, but the reason why I did a second year is because I wanted to learn more stereotactic radiosurgery. So my schedule is a bit less uniform this year, and I'll explain that as I go along. So as basically, I'm going to describe the field, the day-to-day duties of a neurosurgical oncology fellow. We're going to have a case presentation, and then I'll leave it open to questions. But like I said, if anyone has any questions they want to talk about as we go, that you please feel free to stop me. And I just want to see the audience here. Are you guys mainly like pre-med, or you finished medical school? Is that
Hi, I'm Majid. I'm a MD PhD candidate here in Reno at UNR Med,
okay?
incoming third year. So I have the last 2 years of med school to go, and aiming to apply into neurosurgery next year.
Awesome, that's great.
Yeah.
Does Reno have a neurosurgery program?
We do not. We do not. The closest is Davis, UC Davis, and then otherwise I've worked with University of Utah quite a bit.
Okay.
So I actually didn't realize Stanford is near San Francisco. I never realize how close it is. So
Yeah, no,
we're
it
pretty
is.
close
Yeah,
by.
people don't realize it, but it is. We are very
Yeah,
close to San Francisco.
yeah.
Awesome, nice to meet
So
you.
pleasure. Nice to meet you too. Thank you for your time, and looking forward to the presentation.
No problem. Anyone else want to introduce themselves?
Hi everyone. I am Jay.
Hi.
I completed my med school from India, so I'm basically international medical graduate. Currently, I'm pursuing masters in public health at University of Cincinnati, Ohio, and I'll planning to work as a research fellow after I graduate from University of Cincinnati, completing my MPH. And after 2 years, I plan to apply to neurosurgery.
Okay, excellent. Nice to meet you.
Nice to meet you. Thank you for your time.
Yeah, no worries. Okay, anyone else? If not, it's fine. We can just we can move on. So what is neurosurgical oncology? Basically, as you guys probably know, it's a subspecialty within neurosurgery, and it's basically dedicated to the treatment of tumors of the brain and spine, and these can be primary or malignant. And the types of treatment as a neurosurgical oncologist, what you do on a day-to-day basis, and this will vary with your practice, but it's open surgical resection, laser interstitial therapy or LIT, radiofrequency ablation, and stereotactic radiosurgery. So this is a field or a subspecialty within neurosurgery that has a large research component. And so these treatment modalities I mentioned are constantly evolving because there's different combinations, and also there's a lot of drug trials, drug delivery to the CNS, breaking down the blood-brain barrier and the blood-spinal cord barrier, and getting drug penetration. So what I've told you is very fluid, and this is a very fluid field that's constantly changing. Within the last 5 years, it's changed a lot, where we are moving away from open surgical resection in a lot of cases towards more of the minimally invasive things, or a combination of both, which is, really what I've appreciated this year at Stanford. So the day-to-day, this is basically kind of what happened what my schedule was at Yale, and probably for most neurosurgical oncology fellowships. But you have to remember, neurosurgery is a very it's not a predictable field. It's a very unpredictable field, and so this is very fluid. So generally, you arrive around 5:15 to 5:30. You check on the post-op. You do like a quick chart rounds, check the overnight events. You round on the post-op patients or any of the sick patients that are still in the ICU. And then you check in with the residents, usually the chief resident. You do a little bit of a chart round with them on the residents and the chief on the neurosurgical oncology service. And then you meet in the OR around 7 with the attending. You discuss the inpatients, discuss the attending's patients, and then from 7 to 5, you're generally in the OR. Again, this is fluid. This could be much later sometimes. It could be much earlier. And then if you have some time, if you finish a bit early, you can work on research. And then usually around 5 p.m. you have you do like your evening rounds. And usually that's by yourself. You could do it with the residents, but when you're a fellow, you're pretty much independent. And so you do the rounds on your generally your post-op patients or any patients that are sick or not doing so great. And then you can check in with the chief and discuss any issues. And then usually you want to give the attending an update about what's going on with their patients. So that's basically the day-to-day. Any questions on that?
What's been your longest case so far?
Ooh, so the thing is this, when I was working at Yale, I was working with Dr. Jennifer Moliterno. And so she's a very proficient and good surgeon. And speed doesn't necessarily mean that you're good. But her cases went very fast because it's just the way she approached it. And some surgeons aren't so fast, but they're still good. So it's surgeon dependent when you're operating with someone else. But the longest I've had that I can remember has probably been about a 12-hour case, 12-hour really complex glioma during residency. So that was a while ago, and it was 12 hours and it was long. So
that's amazing. Thank you.
But yeah, so that's the one thing about neurosurgery in general. The cases are, I think, and you guys probably understand it, the acuity is high, the patients are sick, and a lot of times the cases are long. So, be ready to have that stamina. And I think that, I think probably most of you guys know about this. So, yeah. So, yep. And so also, some of the other duties are clinic. So this is going to be generally at least once a week. And the night before, you're going to review the charts of the patients, do some pre-charting just to make sure you're ready. And the general clinic workflow is, you see the patient independently, and then you present to the attending. When you present, and this is true of any phase of your neurosurgical training, is to have a plan formulated, because even if it's wrong, you're here to learn, but you also want to show that you've kind of thought about the patients, and you can kind of do a differential diagnosis and also kind of make a plan, because at the end of the day you're working towards becoming independent. And then after clinic, you will generally debrief with your team. That might be with the attendings or the advanced practice providers. It just depends, and those are things that will vary from place to place. So also what's really important in neurosurgical oncology is a multidisciplinary tumor board, and this will be at most academic places which host these fellowships. And so it's generally once a week, and sometimes twice a week. Sometimes you have a spine tumor, or like some places divide it between primary tumors, metastasis, spine tumors. Some places divide it primary spine tumors, and then primary tumors, and then metastatic tumors. So it really depends on the place and the volume. So, but it is a multidisciplinary discussion, and this is very important in neurosurgical oncology. And because you've got as a neurosurgeon, you're not managing you're always especially in academic places, you're managing the patient as part of the team, and you are providing a service in a lot of ways. So, and this could be a service as, providing as simple as just doing it. And I don't want to say simple, but carrying out a biopsy to provide a tissue diagnosis that will kind of drive the treatment. So, and it's really important that you're part of it. You remember that you're part of the team, and this is between neuro-oncologists, neurosurgeons, and generally radiation oncologists. And so usually most patients are presented at this tumor board, and you have a multidisciplinary discussion, and this kind of leads to a formulation of a treatment plan. Now, as a neurosurgical oncology fellow, you're generally responsible for presenting some of the patients. These are usually like the neurosurgery patients, or the patients that come on the neurosurgery service, and making sure all the information is transmitted and put in the chart. So usually you work with the APP in doing this stuff, and the communication is very important to make sure the outcomes of this tumor board are in the chart, so that everyone knows what the plan is. Also, so some places have an on-call requirement. So when I was at Yale, I was taking Tumor Call basically 2 weeks a month and also 2 weekends a month. And this was in-home call. And the resident can call you anytime at night with a new tumor consult. Also about any kind of things that are going on with the inpatients. And you can feel their questions. You rarely have to go in to operate on the tumor service. This is not trauma. It's different. So you rarely need to do weekend cases. I probably did maybe 2 or 3 weekend cases during my time at Yale. And then on the weekends, you go in to round on the tumor service patients, and also see any new consults. And then you talk to the attending about it and formulate a plan. Make sure if it's surgical, make sure that the residents schedule them for surgery and they're scheduled for surgery during the upcoming week. And like I said, you rarely come in to operate. Now, there's also a second component where some places will encourage you and want you to take a general call or general trauma call, and they will actually something pay you extra for this. So this wasn't the case at Yale, but at Stanford they have a bunch of kind of satellite hospitals that they need people to take call on. So that's also good experience for you, as well as like honing your skills as a young attending. That's kind of where that's what the on-call situation is. And then research time. So research time, it really depends. Some places have protected time. Like currently at Stanford, I have 2 other co-fellows, so we kind of rotate through, and we have time to pursue research. We have dedicated time for research. When I was at Yale, I was the only fellow, and so it's a little bit the clinical needs are more important. But I talked to Dr. Malterna was my primary supervisor there, and she was very flexible, and we found time to get some papers out. So research in neurosurgical oncology, as you've probably guessed, is important. So these are things that I think a couple of you have advanced degrees, and I know that having these advanced degrees it's important, and it'll help you by the time you get to that fellowship position, you'll be in a good spot. You'll know how to do research. You'll be in a good spot to kind of drive your own research. And I know if you want to do basic research, there are ways to. It's difficult, and you're not going to be the one necessarily doing the pipetting, but there are ways to kind of use your knowledge to kind of get involved with the basic research component in most neurosurgical oncology. Most neurosurgery oncology fellowships will have neurosurgeons who are doing basic research. Any questions?
Yeah, I had a question like, um, if you're a neurosurgeon and if you look at 2 peoples who are like who completed their medical school and now dedicating their time to research, which will sound more important to you, like one who is clinical research coordinator because he's spending time with patients and doing research, or the one who is a research fellow, which
So that's a good question, and it's hard to answer because that's going to depend on the department that you apply to and the department that's seeing your application, because there's some places where that really emphasize basic research. For example, Stanford, they emphasize a lot of basic research, I think more than the clinical research, even though clinical research is always going to be important. And so like places like Stanford, Yale, they have the facilities for neurosurgeons to have their own lab. Now, if you go to a place that's more kind of clinical heavy and maybe more trauma heavy, less maybe on the oncology side, then they're gonna like the fact that you have this kind of clinical research experience. And you've been a clinical research coordinator, you've been interacting with patients, because trauma is, for a lot of for a neurosurgery center to maintain their level 1 trauma, and most primary sites for neurosurgery residency training in the US are level 1 trauma centers. They need to be doing research, and so a place like that that's more trauma heavy may kind of see that as more important than having the basic research. So it all depends on where you go, and so you got to kind of be aware of where you're applying. Now, the thing is this, like, most in neurosurgery, as you guys know, it's competitive. And so you want to apply apply widely. So there's no right answer. I think at the end of the day, showing productivity, no matter what role you've had, is the most important thing.
Okay.
Is that clear?
Yes, thank you for answer.
Yeah, no problem. So I'm going to do a quick case presentation, and then we'll actually we'll open it up for more time for questions. So before I go into the case, and I think probably you guys know this because most of you guys have done medical school, and so I didn't know who the audience was. So apologies if this is a little bit kind of basic, but so when you work up the neurosurgical patient, as with any patient, you want to get a good history, and so a lot of times, and this is important because you're as a young resident, your first interaction with new patients is going to be mainly in the ED. It's not going to be in the clinic. And so you're probably going to get a consult, and you're going to get a history, a brief history, hopefully, and a good history from the emergency room doc, or the inpatient service that's consulting you. And the thing is this, and it's happened to me before, you get the history, but you can't rely on that. You have to do your own work, because you can get burned because someone's given you, maybe they're busy, they're giving you a really quick history, and then you go quickly to examine the patient. But what I really recommend is, after you get the consult, do a quick look in the medical record, take a look at the patient, make sure you have a good understanding of their past medical history, their social history, and their surgical history, and also what medications they're on, especially things like blood thinners, because this is going to kind of, at the end of the day, you're working for a surgical service, and you may need to do surgery in the immediate period on this patient. And if their coagulation profile is out of whack because they're on Coumadin, for example, you need to know that, and you need to know that this needs to be reversed. Hopefully, the managing service will have already taken care of that, but again, you have to kind of do your own work and your own due diligence, because it's going to be your name on the chart writing that consult report, and you're going to be reporting to your chief and to your who's in turn going to report to your attending. So that's really important, is to get a history and do your own due diligence, even if you get the consult and the history from the managing provider. And then, of course, the physical exam is very important, and this is going to kind of drive your management of the patient. If they have a deficit, are you going to operate? When are you going to operate? And so forth. And then, of course, the labs. And we talked a little bit about the labs and the coagulation profile. You want to check the electrolytes, especially the sodium, because that's important for brain compliance and brain function. And so the labs, the neurological exam are important. And then, of course, the imaging, because generally they're not going to consult you. They're not going to consult neurosurgery unless there's a finding on, a pathological finding on the imaging. And so being able to understand the imaging modalities, CT, MRI, and being able to find these to read these exams by yourself independently without a radiology or without a radiology report is important, because at the end of the day, you're going to have to report this to your chief, and then as you go up the ladder and you become a chief, you're also going to have to be competent. You have to competently report this to your attendings. So the case is, this is something I did at Yale with Dr. Moliterno. Is a 56-year-old male, otherwise healthy, came to the ED with 2 weeks of headaches and blurry vision. The resident called me about this. He had no other symptoms. All his labs were normal. He came, basically his exam was normal. He had no weakness, but he had some blurry vision in his left eye. So I don't know. What would you do? How would you proceed now? You've gotten this story. What are some of the things you want to know?
Certainly, how long has this been going on? Has it happened before? Um, does he have any known sort of pre-existing medical conditions? And probably if we can do an ophthalmological exam on him, and just see if we can do look at his optic disc, for example, and see if there's anything out of the ordinary.
Very good. Yes. So you looking at the fundus is important, because why is that important? You want to give us an explanation about that?
Just in case he has a increased ICP and we're able to notice the retina detaching, that'd be an immediate concern for neurosurgery for us to sort of manage that right away.
Yeah. So looking at the optic disc for papilledema is very important. It is a sign of increased intracranial pressure. A lot of times it's a chronic sign, so it might be not necessarily an indication for acute acute intervention. But yes, you do want to get ophthalmology. You want to look at make sure there's a formal kind of visual fields and a visual exam in the chart, because this is going to help drive your decision making. Very good. And so this patient had this MRI. Someone want to describe this, or I can just go into it? So this is an axial MRI, and as you can see, there is this is a contrast axial MRI, which looks like there is a left frontotemporal contrast enhancing mass. Looks like it goes down to the skull base, and there might be some pressure on the optic nerve there. And anyone want to take a guess about what this might be? So this is likely something called first thing, it's an extraaxial tumor. And the way you can kind of tell there's an extraaxial tumor is it's not a great cut, but you can see here there's there's some pressure. It's exerting some pressure on the brain, and there's some effacement of the sulci and gyri here, and there's some edema. But edema also can be for intraaxial tumors, but you can see it's kind of pushing the temporal lobe back. So this is kind of the thing where, you have to understand the normal anatomy and appreciate the normal anatomy, so you can kind of appreciate what the pathological process is kind of doing to the brain. So this looks like, it's pretty. This MRI is pathognomic for a sphenoid wing meningioma. So, given these constellation of findings, do you guys think this patient needs surgery?
Certainly. We but I think given sort of what from your introduction, you may opt for a non-invasive sort of management approach as well.
And yeah, certainly there are management options here. So, if you are going to do surgery, would you take this? Do you think this patient needs to have surgery really quickly within the next 24 hours? What are your thoughts? I know we haven't gotten the full story, but you've gotten like a basic picture right now. What do you think?
My initial guess would be, given the size of the tumor, probably so, in terms of an emergent case, not necessarily at this moment, but definitely sooner rather than later. But I know meningiomas, I don't know if they grow necessarily, fast. So I don't know if this would expand, if he's presenting with this for the last 2 weeks, and so if we give it another 2 weeks, it may double in size. We don't know.
Okay. So that's good, and that's a very good thought process. For especially you haven't. I'm assuming you haven't done much neurosurgery yet, no sub-eyes or anything like that.
You correct? Yeah, not yet.
So, and that's fine. And so one thing is that generally meningiomas are slow-growing tumors, but again, it depends on their grade, and we don't really know the grade, and you can't really tell the grade of the meningioma by looking at it right now. So on the imaging. So these are generally grade 1 meningiomas, are slow-growing lesions, and this guy's probably had this for probably around 10 years or so, maybe 10, 15 years. And so it's slow growing, and now it's kind of presented itself because it's gotten to this size, it's affecting his vision. And so, yes, I would say he does need surgery, not necessarily emergently, but I would say within the next few days would be good to kind of get this thing out. And so we had the luxury of actually discussing this patient, even though in our heads the answer was clear that this was we wanted to do this surgery within the week, within the next few, I would say within the next 2 to 3 days. We had the luxury of this was kind of falling before our multidisciplinary tumor board. So we, just to get, to cover our bases, we presented him, And so, we discussed a variety of options. You can actually treat these upfront with stereotactic radiosurgery. And stereotactic radiosurgery, it doesn't necessarily decrease the size of the tumor. It just stops it from growing, and it arrests the cells from growing. But given our experience, the consensus of the multidisciplinary group was to go and resect the tumor and get as much out as safely as possible, and then represent the patient after surgery, after we have an idea of how much we were able to resect, and discuss other options. And also, the important thing about surgery is that it gives you a tissue diagnosis. So tissue diagnosis is extremely important in meningiomas and gliomas, because now we get molecular profiling, and this can drive the next steps of treatment. So the patient was taken for a left pterional craniotomy, and I'll go into what that is in a little bit, for resection of the tumor. So not all surgeons do this, but we placed a lumbar drain for brain relaxation. And so this is something that I learned from a trick I learned from Dr. Malaterna. She does this with a variety of her complex skull-based tumors. So what the lumbar drain is basically, before you start the surgery and the patient's under anesthesia, you place a drain, kind of like do a lumbar puncture, but it's a permanent continuous drain. Well, not permanent, but temporary continuous drain in the lumbar spine, usually between L3, L4, L4, L5, L5, S1. And you can keep the drain clamped, and then open it as you're opening up the skull and opening up the dura. You can release CSF to relax the brain, and this allows you to get into tumors it gives you brain relaxation, which allows you to more easily get into tumors that are at the skull base, encased in important vascular structures, without retracting the brain, because retraction of the brain can cause damage. It's not an innocuous process. So she likes this because it minimizes brain retraction. It's something that I will probably use in my practice. And we actually wrote a paper on this, and it was published I think probably around a year ago now about this. So I think this is a nice technique. Now, other surgeons will say, no, you don't need to do it, and et cetera, et cetera. But then it just depends on surgeon preference and who you train with. So the patient we were able to get a gross total resection. And like I said, she's a very prolific surgeon. Even though she does let her fellow do a lot of key parts in the case, she's in good control of the situation. And we were able to get this out in about 2 hours of operative time, which is pretty good for this kind of complex tumor. And I'm going to show you some of the anatomy, and hopefully the video I have works. So patient did well, was discharged home on postoperative day 2. The tissue diagnosis showed it was a grade 1 meningioma, and I'll talk a little bit more about that in a bit. So for this peroneal craniotomy, this is something that's important for you to know. This is kind of like the workhorse of neurosurgery, because it's a simple kind of cranie. It allows you to get into a wide variety of anatomical locations, and so treat a wide variety of pathologies. In our case, it gave us good access to the anterior skull base. This sphenoid, as soon as we kind of opened up the dura, the tumor was we were right there facing the tumor. And so it also has minimal complications. So, and it's basically like a kind of a hairline incision, about 3 to 4 millimeters in front of the canthus. So it's a great procedure. One thing about it is, this muscle here is the temporalis muscle. And so, dealing with the temporalis muscle is complicated, but if you deal with it in a good way, we kind of split it and detach it from the bone, and make sure we don't get into the facial nerve here. Can you guys see my mouse arrow?
Yeah, we can.
Yep.
Okay, great.
Yes.
Make sure you don't get into the facial nerve here. And then when we close up, we reattach it to the bone, and then reattach it to the remaining muscle here. Different people have different ways of doing it. Some people detach the entire muscle and raise a myocutaneous flap. We did this way because I think a lot of our patients are younger, and so we want to kind of retain their functionality of the temporalis. So this is something that you'll be doing a lot in residency. Like I said, it just allows for a great kind of view and a great access to different anatomy. And so this is intra-op. This is so we've turned the cranie now, opened the dura, and now we're working on the tumor. Tumor's up here, and so right now we're kind of detaching the tumor for some of the critical structures. I think that's cranial nerve 3 that we're kind of cutting the tumor. You can see there's like some attachments there to that, and that looks like we're actually that's the carotid. So we're detaching that up from the carotid, and we're kind of rolling the tumor away from the critical structures. There's the temporal lobe there. We're coagulating the vascular attachments of the tumor and then cutting, and that's basically that's the technique you'll be using, is kind of coagulating the vascular attachments and then cutting with micro scissors, make sure there's no bleeding. You can see the key for these is going after the blood supply early of these tumors, so that you can see the surgical field is fairly dry. And so this is very important, is to keep the field dry, because that's going to affect your visibility and your working time and your working channel. So a lot of times this is unavoidable, but what it takes is studying the pre-op films, making sure you understand where the vascular supply is, going after that first, and then that makes your resection easier. You could see there's cranial nerve there, dissecting the tumor away from critical structures again, doing it very carefully, making sure to preserve the critical structures. And I'll tell you this, Dr. Malturna is a great surgeon. Not a lot of people would be able to take this out and get a gross total resection, because it is, I'll show you a picture, it is encasing. There we go. There's the tumor is coming out. And then we're just coagulating our resection cavity, making sure there's good hemostasis, because you don't want to get called by the resident in the middle of the night. There's some remnant tumor, but hemostasis is key. You don't want to get called by the resident in the middle of the night to evacuate a hematoma. And that white stuff there, that's Surgisil. That's just some hemostatic material. You can see there's the ACA and the carotid bifurcation there, and that's the case basically. And let me just and so here, this is the resection cavity now. Here on the left, you can see there's this teronial craniotomy gives you a great view and a great access. You could see the basilar here, so you get access to some of the posterior circulation. The anterior circulation, there's the A1 internal carotid bifurcation. You can see the anterior choroidal, the second cranial nerve, third cranial nerve. You saw us dissecting some of the tumor off the third cranial nerve. So this teronial craniotomy, it gives you, if you ever need to clip an aneurysm, if you need to clip a basilar tip aneurysm, A1, anterior communicating artery, there's an M1, there's the MCA, you can get into the MCA by splitting the Sylvian fissure. So, and then also, if you have like a more anterior skull-based meningioma, like an olfactory groove meningioma, you can use this technique to get there safely, and it really is a beautiful technique. And it's just been used in neurosurgery, from basically the beginning. And so, does anyone have? That's all I have, and so I'm happy to kind of leave it open for questions now.
That was a fantastic case. Very interesting, and I'm glad it went well. So, in your case, did you sort of follow up with any like the follow-up with oncology, and was this patient on given any any medicine?
Yeah, so that's important. I'm glad you reminded me of that. So that's really important at the end of the day, is you do a good case, you get a gross total resection, you see here's the post-op MRI showing a gross total resection of this tumor. And what happens is that you need to follow up with the patient. And so we represented this patient after we got the pathology results back. And it's grade 1 meningioma. So for grade 1 meningiomas, nothing else is needed. We'll generally get an MRI in 3 months and see this patient back in clinic. They'll come back for a first thing, generally they come back for a wound check in 2 weeks. 3 months, they'll get an MRI, make sure everything looks okay. And then we'll follow up in 6-month intervals, and then after a year out in 1-year intervals for grade 1 meningiomas. Now, if this has been a grade 2 meningioma, then you need to do radiation generally to the resection cavity, because grade 2 meningiomas have, and higher grade meningiomas, grade 3 meningiomas have a high recurrence rate. And so the imaging your imaging frequency is, the interval is a lot less. And then this patient would have been, if this was grade 2, would have been referred to some type of radiation to the resection cavity. And that's how we would have proceeded. So, and that's very important in neurosurgical oncology, is that, patient follow-up is extremely important, because these tumors can recur, and you want to stay on top of it, and you want to make sure they're referred to the right team, radiation oncology or neuro-oncology, for clinical trials, or chemotherapy, radiation therapy. It really is, and this goes back to what I said before. It's a multidisciplinary team effort.
That's fantastic. And follow-up question: had this been a GBM, and say it had optic nerve invasion, would that sort of have changed the whole sort of case at that point, right?
Yeah, so if this would have been an optic pathway glioma, the management of that is a little bit different. So it's, you want to, and especially in young patients too, you want to resect as much as possible and also try to preserve vision. And with GBM, the standard of care right now that we have is the Stoop protocol, which is, maximal safe resection followed by chemotherapy and radiation. And this is the kind of the protocol standard of care we've had for the last 25, 30 years, and the results aren't great still. And so, GBM it's an active area of research, and it's a very difficult tumor. And also, what another thing you need to understand about GBM is it's an intraaxial tumor. So with meningiomas, especially with grade 1 meningiomas, you rarely get brain invasion. You get nice planes between the brain and tumor, and between critical structures. And so the resection is generally easier. The problem with GBM is that you see the contrast enhancing part on the MRI, but there's also microscopic tumor as well that you don't see. So you try to do maximal safe resection, and the standard of care is to resect the contrast enhancing part. But depending where you are on the brain, especially if you're in a sensitive area like the optic pathway, you're limited by what you can do. And so you do what you can, try to preserve function, especially in young patients, and let the multidisciplinary team take control. But as a neurosurgeon, you are also wanting to surveil these patients, because a lot of times, especially with GBM, these recur, and they may need surgery again. So it's really important. Follow-up is very, very important. I'm glad you brought that up.
Certainly. Oh, thank you for the answer. Yeah, that is interesting. And I mean, what, in your opinion, what's the sort of next key breakthrough in terms of GBM treatment? What is Stanford, what are you seeing there in terms of these new technologies?
There's a lot of trials for GBM. There's a lot of trials for GBM using stereotactic radiosurgery, and also kind of bringing in immunotherapy. So the head of our department has a trial with immunotherapy for GBM. And so I believe it's just been getting started out. So I think immunotherapy has done really well with treating metastasis, especially small metastasis. I think it's going to be more difficult for treating GBM, because these are kind of more diffuse tumors, and there's such a lot of microscopic spread that you don't see on imaging. And so this is going to be very difficult. But one of the things that is happening at Stanford is this immunotherapy. Also, the radiation oncologists have trials with stereotactic radiosurgery. Unfortunately, the stereotactic radiosurgery for GBM, because it is so diffuse, it's really hard to target it. And stereotactic radiosurgery is very precise, focal radiation. So
yeah, I did in my first year of my PhD, I did stereotactic neurosurgery in mice, and you're off by 1 millimeter and you're hitting a different target than you want. So totally get that. Yeah.
Exactly. Yeah, that's the thing. And so, I don't know what your setup is for doing it in animal models, but we have we use at Stanford, we use the CyberKnife system, which is very accurate, has a great treatment planning system. So, all these are very, very important. So yeah, but it's great. You have an appreciation for that. That's great.
Yeah. Have you sort of come across this field of connectomics and sort of looking at the white matter tracks and seeing,
So yeah, that's a very important
that
field, especially for brain tumor resection. And I've seen it a lot. I've read a lot. Hughes Defoe, who's somewhere in Canada, I believe in Montreal. He's published a lot on connectomics, and mainly his life's work has been mainly with insular gliomas. And these are gliomas that are in eloquent language areas, and how much you can safely resect, mapping, things like that. And for GBMs, a lot of times, I did a lot of cases with Dr. Malterno with GBMs in eloquent areas, and we had a great team for doing awake craniotomies. Again, this is neurosurgical oncology. It's a real team effort, and we had a great team. And so to do an awake craniotomy properly, you need a good anesthesiologist, a good scrub team to get you the instruments in a timely manner, and then also the neuropsychologists who are talking to the patient under the table and keeping them calm while you're resecting this tumor. And there's a lot of operative adjuncts for resecting gliomas in these areas. Usually, we get something called diffusion tensor imaging, which I'm not sure if you're familiar with, but lets us see the white matter tracks in relation to the tumor, and we use that intraoperatively in our navigation system. We use a subcortical stimulation on our suction, which can stimulate the white matter tracks in real time and tells us when we're going a bit too far. So, there's a lot of operative adjuncts here. I kind of gave you a simple-ish case, even though this is actually a complex skull-based tumor. But there's, like I said, neurosurgical oncology is multifaceted, and there's a lot of tools, and there are a lot of emerging tools, because it is a research-heavy field.
Certainly. No, thank you for that. That's beautiful and very interesting. It's definitely exciting for us to sort of be, coming into the field at this time too, with all this great technology and advancements going on. So that's
yeah,
awesome.
and I think it's a great field to be in. So
And I actually had a question.
Yep.
Given your expertise in like a PhD in computational chemistry, how do you see artificial intelligence, deep learning models, and computational methods and algorithms come into play for neurosurgery?
I think these are going to be very important, and they're already being used. I'm collaborating now with some of our physicists, and we are just submitting a paper on some deep learning models we use to predict survival in GBM. And these models are going to be very they're constantly being refined, and by physicists and computer scientists, and it's really important to have collaboration. So I've had a great collaboration with the physicists this year at Stanford, because we help them with the clinical side, they help us with model development, and it can I think this is really important, and it is the future. Now, what's going to kind of be limiting in it is the computational power and the quality of the algorithms, right? But as computational power is continually increasing, and also quantum computing is coming into the picture, this is I think we're going to have some good possibilities of doing some quality research and really making changes, positive changes in patients' lives. But it's still like an emerging field, and it's going to take a lot of collaborative efforts, I think, between neurosurgeons, clinicians, and physicists. That's my feeling about it.
And kind of a follow-up question on that. In the near future, like our career time and your career time, do you ever see like AI robots completely taking over for neurosurgeons?
I don't, because it's such a field where, and but this could change, but it's such a field where when you're working in surgery, snap-second decisions are needed to be made, and I don't think we're there yet. Now, robotics does have a big part, is starting to emerge in neurosurgery, and more in spinal neurosurgery, and this is more along the lines of getting the patient set up and targeting, navigation and targeting. I think in other fields like general surgery, you have the Da Vinci robot, which is probably has a bit more capabilities as far as helping the surgeon intraoperatively. But I think there's a future, but I think you will always need the guidance of a surgeon for these robots. Does that answer your question?
Yes, it does. And in fact, correct me if I'm wrong, it was in Florida somewhere where they did the first robotic guided skull-based surgery or something like that. I might be wrong. I just kind of passed it.
I did not. I have not heard about that. Do you know where it was?
Man, I just kind of passed it by on Instagram. I'm not real sure, but they were making a big announcement, like a first robotic brain case or something like that. I'm not sure if any of you other guys are familiar here.
Okay. Anything, any other questions? All right, well, thank you guys for your time. I hope that was helpful.
Yeah, thank you so much,
Yes, it
Neelan.
was
This
very.
was
Thank you.
amazing. Yes, yes.
Thank you for your time.
Thank you.
No problem, guys. Nice meeting everyone.
Thank
And
you.
also, if you guys have any questions, feel free to reach out. I know some of you may be planning sub-Is and things like that, so or have application questions, and I'm happy to help and guide when as needed. Okay.
Thank you so much. How should we get in touch with you? Your email.
Let me just leave my email.
Okay.
in
Thank you so
the-
much, yeah, for being willing to do that. We really appreciate it, especially as we're, I think all of us here on the call are aspiring, neurosurgeons. So it makes a big difference for all of us.
Yeah, definitely. Feel free to get in touch. I may not answer right away, but I'll definitely get back to you guys. And if you need help planning applications, things like that, maybe we could even schedule phone calls down the line, things like that. So definitely happy to help and give advice. I know this is kind of a daunting field and a daunting task, and doing the sub-Is, and it's a difficult, time-consuming, expensive process. So really happy to help.
Thank you. Appreciate it.
And
Thank you,
Neelan, real
everyone.
quick,
Take care.
I've actually recorded this session. Is it okay if I post this on our YouTube channel?
Yeah, definitely. You can definitely do that. 100%.
Okay. Thank you, Neelan. Thank you so much for your time.
All right, no
Thank
problem.
you.
Thank you, everyone, for joining.
Bye.